So basically the knee is a joint for the lower limb. It is composed of the femur and the tibia and the patella. This is the bone anatomy of the knee plus the fibula on the lateral side. And to function, this joint needs ligaments to keep the two big bones together. So in the knee, we have 4 major ligaments, 2 inside the knee, the anterior and posterior cruciate ligaments, and 2 outside, 1 medial and 1 lateral. The anterior cruciate ligament is very important for the stability of the knee, mainly for anterior and posterior stability. We know that if this ligament breaks, then people complain about problems of instability. So if you want your patient to go back to playing sports, we need to reconstruct this ligament. We have developed different tests to confirm the complete heel of ACL ligament. Most often in clinical practice, we are utilizing the Lachman Test and the Pivot Shift Test.
Lachman Test and the Pivot Shift Test.
The Lachman Test is recognized by most authorities as the most reliable and sensitive clinical test for the determination of anterior cruciate ligament integrity. To do this, the patient's knee is put in about 20 to 30 degrees flexion. The medical doctor pulls on the tibia to assess the amount of anterior motion of the tibia in comparison to the femur. An ACL deficient knee will demonstrate increased forward translation of the tibia at the conclusion of the movement. For the pivot shift test, knee is extended and internally rotated. The medical doctor applies stress to the lateral side of the knee while the knee is being flexed. A positive test indicates a crash felt at 30 degrees flexion. The diagnosis of a lesion is facilitated by the rigorous clinical examination of the patient and confirmed thanks to the magnetic resonance imaging or MRI. MRI means magnetic resonance imaging. It's a form of scanning which uses magnets and RF pulses, and it's ideal for musculoskeletal work. So the procedure is not at all painful. The only thing the patient complains about is the noise. It is noisy, so we give ear protection such as earplugs or earphones to protect the patient. There are questions regarding the safety, especially for metal, for patients who have certain types of metals in their body or implants such as a pacemaker. These patients cannot be scanned, so we do the safety check 3 times before the patient goes into the scanning room. The average length of the time for an MRI scan is 30 minutes from start to finish. It can be slightly longer or slightly shorter, but the average is 30 minutes. After MRI acquisition, the patient meets a radiologist. He shows the X-rays to the patient. Compared with an intact ACL X-ray, the radiologist determines exactly the nature of the injury. When a patient has an injured ACL, very often this is accompanied with swelling, some muscle stiffness, and reduced range of motion. What we like to do is, before the patient goes for surgery, is to help the patient recover his range of motion and to get his muscles to work again. The objective is to facilitate both the surgery itself and post-operative rehabilitation. Prior to surgery, the patient will undergo a preoperative assessment. During this assessment, the medical team will determine the suitability of the patient for surgery and provide pre-operative and post-operative information. The physiotherapist will evaluate the knee range of motion, swelling, walking pattern, and the ability of the patient to perform functional activities. The patient will be educated on the safe use of crutches and taught on the post-operative exercise regime. It is of great importance that the patient attends and completes a preoperative physiotherapy program prior to surgery. The physiotherapist will educate the patient on the rehabilitation process and prescribe exercises at this stage to reduce swelling, increase pain-free range of motion, strengthen the muscles, improve walking, and restore normal knee function within limitations. It is essential that all patients who plan to undergo ACL reconstruction surgery understand that their compliance with the rehabilitation program is of paramount importance in ensuring maximal potential following surgery. Patients are usually admitted the night before surgery. This is done so that the nurse can give you some education on what to expect before and after the operation. Patients can expect to remain in hospital until the third day post-operatively, and then they are sent home. All our rooms are single rooms, all with their own bathrooms so that patients can be assured their privacy during their stay. We do have a larger VIP suite, which you can look at before you come in for your surgery in case you would like to book that room instead. When the patient has decided to have surgery at Aspetar, he will be referred to the Preoperative Assessment clinic, where I will see him. Then the anesthesiologist will go through the patient's history and make plans for what type of anesthesia he's going to have. On the morning of surgery, the patient will come down to holding bay, where we will go through our preoperative checklist. We'll be checking if the patient is fasting, that the areas are marked, and that everything is prepared in the proper way. We will also attach our monitors, our blood pressure cuffs or ECG. These are all the things we need to keep an eye on the patient during surgery. For an ACL reconstruction, you can have a general anesthesia, which means that you are sleeping during the procedure. Or you can have a regional anesthesia, which could be a spinal or an epidural. Most of our patients are young and healthy athletes, and for them, general anesthesia is preferred. It gives them shorter immobilization time afterwards. After the surgery, the patient wakes up after a couple of minutes in the recovery room. Before we wake the patient up, we give the patient a number of analgesics to keep the pain away, and usually after ACL reconstruction, pain is not a big problem. And if the patient feels a little bit of pain, we can give him a little more pain control. The arthroscopic procedure replaces the damaged or torn anterior cruciate ligament, ACL, with a portion of hamstring tendon from the patient leg. The surgeon uses a small video camera called an arthroscope to see inside the knee during the procedure. Through a small incision below the knee, portions of the hamstring, semitendinous, and gracilis tendons are separated from the muscle but left connected to the tibia. These strips are braided together to create a section of tendon called an autograft, which will be used to replace the damaged ACL. With the knee flexed, the damaged ACL is cleared away. Through tunnels in the tibia and another in the femur, the surgeon inserts a pin diagonally, which is going to serve as a guide to recreate the ACL. The graft is pulled in these tunnels from bottom to the top. The graft is embedded into the bone securely with the help of screws, staples, or other systems. The ACL procedure is finished by testing the knee flexion and extension through its full range of motion. And as a sports dietitian, my role is very important to make sure that the athlete, during his rehabilitation period after surgery, does not gain fat mass or the least possible. Because we know that if an athlete gets injured, he'll stop training, and if he stops training, he usually continues to eat in the same way as before. But then his energy expenditure is completely different. His energy consumption and metabolism is much slower. Nutrition provides vital support to the healing and rehabilitation process. Proteins, carbohydrates, and energy must be sufficient to avoid loss of muscle and minimize fat increase while promoting healing and good health. Early and continuing nutritional intervention and support are essential to ensure nutrient and energy requirements are met throughout recovery and rehabilitation. The nutritional intake is adjusted regularly according to the stage of the recovery. For example, immediately post-surgery, increased protein is usually required, and as rehabilitation becomes more active, overall energy intake must be increased. Nutrition is very important for them. My advice is to come and see us right away after surgery. We can adjust their intake and modify their dietary habits. I can also give them additional advice, for example on fiber foods or other foods that are filling. My first contribution is to inform. Inform the athlete so that he better understands and copes with the treatment, which will last for 6 months. And then I want to tell the patient that he might be experiencing some emotional or psychological difficulties due to this injury. After the surgery, we need to provide psychological support to the patient and talk about the best ways to manage and deal with the pain to reduce it. We've obtained very good results on pain reduction through relaxation techniques and, most important, mental preparation before going back to the field. This is done by mentally preparing yourself on how can I boost my motivation, how can I fix myself new objectives, or how will I manage my career. The next phase consists in stopping to completely invest yourself in your knee and seeing the future as being bright. If rehabilitation does not include a psychological approach, then naturally anxiety increases more, and this is generally a cause for further injuries. I always encourage the patients to ask their questions or seek advice from a health professional. When a patient comes to see us after surgery for rehabilitation, we try to give him a series of exercises which are easily reproducible at home. These exercises will also be helping the patient with any post-operative complications he might experience, such as swelling and reduced range of motion. The ACL in patient's rehabilitation starts immediately after surgery as soon as the patient is awake and coherent. The patient is asked to perform a few exercises every hour to maintain good knee function. The exercises are basic but very important to control swelling, regain knee range of motion, improve circulation, maintain quadriceps control, and regain the neuromuscular control required during normal daily activities. At the end of each exercise session, the patient will be asked to apply ice to the knee for 15 minutes. The physiotherapist will educate the patient to safely transfer in and out of bed, walk using crutches, and ascend and descend stairs in preparation for home discharge. At this stage, the patient should limit walking distances, gradually increasing distance on a daily basis to avoid excessive swelling. When sitting, the operated leg should be elevated. We recommend praying to be performed in a chair for 6 months following surgery to protect the reconstructed ACL. An ACL reconstruction is not an out-of-the-book solution. When patients undergo their surgery, it is very important to do the exercises regularly, especially during the first phase of rehabilitation. Here, the exercises are done on a daily basis. The patient will do the exercises for about an hour, but we will also ask the patient to repeat these exercises at home. In this phase of rehabilitation, patients will attend the early ACL group 5 days a week. The prescribed exercises aim to improve static knee stability and alignment, increase quadriceps control, improve walking pattern, increase knee range of motion, and reduce pain. General strengthening will be initiated. The exercises should be performed pain-free and at a low intensity with focus placed on quality of movement and correct alignment. Once the wounds are healed, the patient will start hydrotherapy. Fitness training will commence when the patient can mobilize unaided. The patient will be responsible to continue a home exercise program 3 times daily. The amount of exercise is very small and only lasts 15 minutes, but it's very important to repeat these exercises on a regular basis. At 6 weeks, we start to do a lot more functional exercises, so we start to do a lot more daily movements as part of the rehab program. The patient will progress to the intermediate ACL group, attending 5 days per week. Exercises will be both machine and circuit-based, incorporating muscle strength training, balance, core stabilization, and knee control and correct alignment in more dynamic situations. Focus will be placed on the knee. Towards the end of the intermediate phase of rehabilitation, the patient will complete a Biodex strength test. A successful test, along with the achievement of specific parameters, will enable progression to the final advanced ACL group. In the advanced ACL group, patients will continue to attend 5 days a week, incorporating physiotherapy, fitness, and sport-specific training in addition to the previous exercise program. The patient will commence a running progression, including straight-line jogging, sprinting, acceleration, deceleration, and cutting. A jumping program will commence at this stage and will educate the patient on correct alignment during a multitude of jumping and hopping functional activities. In this phase, strengthening will focus on specific deficits observed during functional exercises or seen on biodex testing. Strengthening should be sport-specific, considering endurance and explosivity. As previously, correct alignment and mechanics should be ensured during all exercises. Strengthening exercises in this phase can occur in less controlled environments, with focus on functional and sport-specific movements and the use of free weights. At the end of this phase, the patient will complete a number of pre-discharge tests to assess functional ability, strength, knee control, and capability to return to sport and normal activity. The best advice that I would have for the last period of rehabilitation is that it can take time. It is important to keep your motivation. Stay motivated because with the rehab, it can be repetitive because you're doing the same exercises day after day. It can be difficult to see your progress towards the end of the rehab, but with time you will improve. The most important is to stay motivated. The last phase of the rehabilitation consists in getting the athlete to go back to normal life activities. 3 months after surgery, the patient comes back to the field. He starts with basic direction exercises like zigzags and side steps. Then the intensity and the difficulty of the exercises are increased. When the athlete is able to complete correctly all the direction changes, he begins jumps on 2 legs and then on 1 leg. He carries on his rehabilitation with side jumps and springs. Then he starts his sports with specific exercises. For example, a football player is back to the field with basic passes, crosses, and he plays one-on-one. Finally, he practices combinations of all these exercises as close as possible to the real sport. They have to be patient since this type of injury takes a long time to heal. Generally 6 months. So very often the athlete gets bored and tired of being in rehabilitation. Yet they have to remain focused and continue their work.